Good morning, everyone. My name is Dr. Shelley Wang, and one of the neurosurgeons, pediatric neurosurgeons at Nicholas Children's Hospital. Thank you so much for giving me the opportunity to speak today about a genetics of common pediatric neurosurgical conditions. Let's get right to it. So my objectives today is to provide a brief overview of genetic abnormalities and the mode of inheritance. And I like to provide a broad strokes perspective with focus on many different aspects of pediatric neurosurgery. So not just neuro-oncology, which is the field you're probably most familiar with the underlying genetics of, but also to touch upon other fields of pediatric neurosurgery that is pertinent to both a pediatric and adult neurosurgeon. So conditions like epileptic disorders, neuro-oncology, neurovascular conditions, and congenital neurosurgical anomalies. So I would like to focus on the genetic basis of surgical epileptic disorders with a focus on Troubastrosis Complex, Weber syndrome, and malformations of cortical development. Then move on to the genetic basis of neuro-oncology with a focus on Neurofibromatosis I, Neurofibromatosis II, and also von Hippel-Lindau. Discuss very briefly the genetic basis of some neurovascular conditions like cavernous malformations and moyamoya disease, and then lastly touch upon genetic neurosurgical anomalies, including craniosynostoses and hydrocephalus. And you will see that from some of these conditions that this is also very prevalent to the adult population. So I'm hopeful that this lecture will be helpful to adult and pediatric neurosurgeons alike and will be relevant to your practice and also while preparing for your boards. So thank you very much for allowing me this opportunity. Furthermore, throughout the entire case, I will provide probably a dozen different examples of conditions that we have treated here at Nicholas Children's Hospital to provide you case presentations and examples that can make it more relevant to apply what I'm talking about in this presentation to your daily practice and apply it to neurosurgery. I will not be covering a lot of the underlying submolecular analysis or some of the more detailed neuro-oncology advancements that we have made over the past decade. I will be talking in broad strokes, however, and we'll be talking about some common genetic abnormalities. However, I will not be discussing these recent neuro-oncologic advancements of specific tumors. As you can recall, Dr. Niazi gave a great talk a few months ago about the genetics of pediatric brain tumors, and others like Michael Taylor, Cynthia Hawkins have given really great talks about the advancements of molecular genetics in medulloblastoma and ependymoma, and also the discovery of H3K27 mutations in melangliomas and how they are applicable to pediatric neurosurgery. So I will not be going into some of the details of that, although I do recognize that they are very important. The topic today and my goal today is to give you a more of a broad strokes understanding of not just neuro-oncology diseases, but also neurovascular, epilepsy, and other congenital genetic underlying issues. So to just take this as a very preliminary understanding of genetic disorders. Classification of these genetic disorders include single gene mutations, so whether it's an autosomal dominant disorder, autosomal recessive disorder, or sometimes in the case of males, an X-linked disorder, variants in genes, so having multiple genetic abnormalities with interaction with the environment, leading to different phenotypes, and then of course chromosomal imbalance. Others like mitochondrial disorders and epigenetics is also important, but most of the conditions featured in my talk will be either single gene genetic disorders or multifactorial diseases and their interactions with the environment. So moving on to my first objective, so since I focus on epilepsy surgery, we will talk firstly about the genetic basis of surgical epileptic disorders first. So these are disorders that you will be able to see as a neurosurgeon, whether a pediatric neurosurgeon or adult neurosurgeon. So I think these are some of the conditions that are important to know about. The genetic of epilepsy is quite complex, and we have actually made great progress in the understanding of the genetics of epilepsy over the past couple of decades. And many large and comprehensive pediatric epilepsy programs, like the one at Nicholas Children's Hospital, has made genetic panels and genetic testing standard of care for workup of patients who present to our center. We have made much greater understanding recently about many of these neurologic disorders that you see, but also a significant understanding into the genetic basis of epileptic encephalopathy, for example, Derivate Syndrome. Derivate Syndrome has also been in the spotlight as we now recognize that there are loss of function mutations, such as the one in SCN1A, leads to Derivate Syndrome, which is a childhood disorder associated with frequent seizures, cognitive encephalopathy, and seizures usually occurring before 1 year of age. And it codes for a type 1 voltage-gated sodium channel leading to seizure activity and cognitive dysfunction, and is amongst a family of channelopathies. You can also see Fragile X syndrome can also lead to intellectual disability and seizures in about 10% of the population. It is characterized by intellectual disability, distinct facial features, and autism spectrum disorders, mostly in male. However, a milder form can also occur in females. Rett syndrome is an X-linked dominant pattern, usually occurring in females, and leading to mutations in MECP2 gene with progressively worsening neurologic disorders. Familial temporal lobe epilepsy is also something that's very interesting, and we have now seen multiple animal and human studies published recently with twin or familiar studies looking at the genetics and the family history of patients with temporal lobe epilepsy. The conditions that I will be focusing on during my talk are more relevant to the neurosurgeon. So they're surgical epileptic disorders, and they include TSC, Sturge-Weber, and malformations of cortical development, including megalencephaly, hemimegalencephaly, and focal cortical dysplasia. And I will also talk about their underlying genetic abnormality and genetic mutations for them as well. So starting off with TSC, or Troubastrosis Complex, it's a multi-system genetic disease leading to benign growths in the brain, skin, kidneys, heart, eyes, and lungs. And it was initially recognized in the early 1990s and 1900s, and a classic triad was established by Vo back in 1905, I believe. It includes a triad of mental retardation, epilepsy, and sebaceous adenoma. The most common CNS abnormalities include cortical tumors occurring in about 90% of the population, subependymal nodules occurring in 80% of the population, which are seen on CT as periventricular areas of calcification that may progress to enlarging to subependymal giant cell astrocytomas, which is a WHO grade 1 slow-growing tumor, but often leading to hydrocephalus, obstructive hydrocephalus when it grows around the foramen of Monro. And furthermore, we also see white matter heterotopias. Epilepsy is the most common manifestation, occurring in about 90% of TSC patients. And they have seizures manifesting as simple partial, complex partial, or generalized clonic seizures, mostly occurring before 2 years of age. So approximately 90% of the population will have seizures, and infantile spasms is an early manifestation of these seizures that can occur in about 20 to 30% of the population, and progressively more than 50% of them become medically refractory. Cognitive impairment and TSC-associated neuropsychiatric disorders are also quite common. And as a pediatric neurosurgeon, you'll be frequently encountering this disease due to its seizure, in addition to less frequently its hydrocephalus manifestations. When it comes to managing seizures caused by tuberous sclerosis, seizure surgeries including tuberectomies, lobectomies, multilobar resections, and other palliative procedures like corpus callosotomies and VNS are all potentially employed for this population. When it comes to hydrocephalus manifestations, Oftentimes, you will be you will encounter patients with hydrocephalus and SEGA needing a shunt or septostomy. TSC is inherited through an autosomal dominant pattern, and it occurs 1 in 6,000 births. And TSC1 and TSC2 code for one of two different proteins called hamartin or tuberin, and they bind in vivo to promote cell arrest, and therefore they're considered tumor suppressor genes that regulate cell proliferation and differentiation. TSC1 is located on chromosome 9q, and it encodes for protein hamartin. It leads to worse phenotype of the two types. TSC2 is located on chromosome 16p, and it is encoding for protein tuberin, and it leads to a better phenotype. As you can see here, this is the manifestation, multiple multisystemic manifestation of this disease. As you see, CNS manifestations are very common. Furthermore, skin manifestations like angiofibromas are common. Other major organs are including heart, kidney, lung, and eyes are also involved. On gross pathology, this is what you would see on gross pathology sections. First of all, you see on here a picture of a SEGA, so a subependymal giant cell astrocytoma occurring very near the foramen of Monro, leading to obstruction and increased ventricular size. Here you can see pictures of subependymal nodules, which show up on CT as little calcifications that are periventricular. And then lastly, you see white matter heterotopias. And TSC1 and TSC2 are both tumor growth receptors, but involved in the mTOR pathway. And the mTOR pathway has been discovered for about a couple of decades now. And loss of TSC1, TSC2 leads to an increase in mTOR activity. And there's been recent discovery of mTOR inhibition in the rapamycin, probably about a couple of decades ago. And mTOR inhibitors include sirolimus and everolimus. And this paper is from The Lancet, published in 2016. And it is the results of the randomized controlled trial called EXIST-3, basically looking at placebo, low exposure or low dose everolimus versus high dose everolimus. And the conclusion of this randomized controlled trial is that everolimus, which is a mTOR inhibitor alongside sirolimus, is effective in controlling seizure frequency. So this was published in 2016, and the use of mTOR inhibitors has increased for both oncologic purposes, but also for control of seizures. Let's move on to a couple of interesting cases. This is a 3-year-old boy, a patient of ours at Nicholas Children's Hospital, presenting with developmental delay, seizures, and enlarging SEGA and obstructive hydrocephalus. You can also see here, as you see best on CT scan, evidence of these little calcifications along the ventricle. These are pretty classic radiographic features of TSC. And in fact, on one of my mock boards, I got a case where there was a patient with hydrocephalus and multiple calcifications along the ventricle. And the question that was asked of me is make a diagnosis with just the CT. So this is something that you may be able to see on your boards for the residents in the future. So as you can see here, a sizable SEGA in the left, around the left foramen of Monro. There's multiple subependymal nodules along here, and the patient was experiencing acute symptoms from the hydrocephalus. So therefore, we performed an interhemispheric transcallosal resection of the tumor, as you can see on this image here. And following surgery, the patient did well and was started on everolimus for both tumor control and also for epilepsy. Another case of a patient of mine with Troubastrosis Complex. This is a 20-month-old girl presenting to us with developmental delay medically refractory seizures. She was found to have medically refractory seizures since about 6 months of age and found on imaging to have multiple tubers. And classic cortical tubers that are the classic manifestation of TSC. Further investigations pointed towards a dominant left temporal tuber leading to some abnormal activity, and she underwent left temporal tuberectomy with intraoperative ECOG. She is not seizure-free, however, she is enjoying decreased seizure frequency and intensity. Oftentimes, as I mentioned previously, in patients with TSC, we frequently perform tuberectomies, two-stage implants, followed by tuberectomies, lobar resections, multi-lobar resections, sometimes hemispherectomies, and then other procedures including corpus callosotomies, a VNS in appropriate cases. Moving on to another disease leading to epilepsy in the pediatric population, we have Sturge-Weber syndrome. Sturge-Weber syndrome is less common than TSC, but you'll probably encounter this at some point in your careers. But it is a mutation on the GNAQ gene on 9q21. It's a sporadic condition occurring in 1 in 20,000 to 1 in 50,000. And there's a classic port wine staining of the face, forehead, and scalp that is caused by excessive capillaries on the surface of the skin, and also neurologic manifestations from excessive capillaries along the ipsilateral brain. You can also see soft tissues hypertrophy and sometimes glaucoma in these patients as well. The neurologic manifestations include developmental delays, focal neurologic deficits, weakness, and oftentimes epilepsy. And what you can see here in the bottom right corner is a classic CT scan of Sturge-Weber. We call it train tracks, so significant calcifications along one side of the brain. And then, as you can see here from these pictures, evidence of retinal eye manifestations, and then this classic port wine staining along the face. This is a case of a patient with Sturge-Weber syndrome managed at Nicholas Children's Hospital. This patient is a 10-year-old girl with medically refractory seizures since about 1 year of age. And the patient came to us with simple partial and complex partial seizures. And because her seizures were not managed with medications alone, she underwent hemispherectomy, and she is now seizure-free for almost a decade. When we review our institutional data of our hemispherectomies performed over the past 30 years, we have performed 4 hemispherectomies on Sturge-Weber syndrome, and this accounts for about 3.1% of our entire cohort. So we've done more than 130 hemispherectomies over 30 years, and 4 of them have been hemispherectomies for Sturge-Weber. When we look at the average age of seizure onset in our cohort, it is approximately 5 months of age, and the average age of surgery is 5.7 years. And at 2 years after surgery, 50%, or 2 out of the 4 children with Sturge-Weber syndrome, are completely seizure-free. Looking at another condition leading to seizures are malformations of cortical development, and they're really a spectrum of different surgical conditions ranging from megalencephaly, hemimegalencephaly, to focal cortical dysplasia. And we have really had greater understanding into the genetics of these conditions recently by understanding into their genetic underlying conditions through the PI3K and AKT pathways. You probably recognize this table. This was published in Epilepsy as a 3-tier IELE classification of focal cortical dysplasias. This was, I believe, published a few years ago in Epilepsy 2011. And essentially it talks about different types of cortical dysplasias, ranging from focal cortical dysplasia type 1, which are focal cortical dysplasias with abnormal radial cortical lamination in the case of 1A, tangential cortical lamination in the case of 1B, and both radial and tangential cortical lamination abnormalities in 1C. Focal cortical dysplasia type 2 are abnormal. Our focal cortical dysplasias also associate with dysmorphic neurons. So in the case of 2A, they're FCD with dysplastic neurons. In the case of 2B, they're dysplastic neurons with balloon cells. And then lastly, focal cortical dysplasia type 3 are also, focal cortical dysplasias also associate with another underlying lesion. In the case of 3A with hippocampal sclerosis, with 3B with glial tumors, or in 3C with vascular malformations, and then in 3D with other kinds of abnormalities acquired early in life. And we have had greater understanding of the underlying pathway for focal cortical dysplasias, hemimegalencephalus and encephalus, and megalencephalus as well through the PI3K-ICK pathway, as you see published here in Brain. So as a couple of examples, here we have a baby boy with seizures since 1 day of age, which quickly became medically refractory. He was very quickly referred to our center, Nicholas Children's Hospital, and then underwent an hemispherectomy at 4 months of age. This patient has been seizure-free for over a decade. And again, when I reviewed our 30-year history of hemispherectomies, we have performed 22 hemispherectomies on hemimegalencephaly, which accounts for about 17% of the entire cohort. And patients with hemimegalencephalus really had the youngest age of seizure onset, especially when looking at our cohort, averaging between since birth, so 1 day of age, to a few months of birth, and averaging at around 1 month of age. And really, of all of the etiologies we've looked at, hemimegalencephalus produces seizures at the youngest age. And they're also the youngest at seizure surgery as well, at 1.9 years of age. When we look at outcomes of these children, 74.4% of them had Angle 1 classification, so seizure-free at 2 years of age, which is quite good. Oftentimes at our institution, we will see them quite early on. We will refer them obviously to our neurology colleagues. We'll do a complete workup, and we'll consider surgery when they're after about 2 or 3 months of age, once they're old enough to be able to tolerate a large procedure like a hemispherectomy. And our outcomes for our institution have been quite good. This is a patient of mine with focal cortical dysplasia, which had also very good seizure outcome. She's a 15-year-old girl. She has a 3-year history of medically refractory seizures characterized by leftward gaze, behavioral arrest. She was found on video EEGs to have right frontal ictal onset. MRI, as you can see here, was negative, and PET showed a right frontal hypometabolism area, hypometabolic area. She underwent a 2-stage implantation with functional mapping. We were able to capture ictal and interictal activity, and this was the final result of our functional mapping with our ictal and ictal activity as well. And this is our final resection plan, which was a corticectomy. She underwent the procedure with no issues. She's 6 months post-op and seizure-free. Final diagnosis was focal cortical dysplasia type 2A. Moving on to another completely different subspecialty of pediatric neurosurgery, looking at oncology. Lots of different kinds of syndromes, genetic syndromes, and conditions have an underlying genetic abnormality. I don't have the opportunity to go through all of them, but what I wanted to focus on today are Neurofibromatosis 1, Neurofibromatosis 2, and then von Hippel-Lindau, which alongside the submolecular genetics of medulloblastoma, ependymoma, ATRT, midline gliomas are some of the most common things that you'll see. And then, of course, as we mentioned previously, TSC also leads to SAGA, which is a low-grade tumor, but I have already covered it in my epilepsy portion of the talk. Lee-Fraumeni is the other one that I will not have time to go through. It is a p53 mutation, and in the pediatric population, what you will see is association with some brain tumors, including core plexus carcinomas at an early age. So looking at neurofibromatosis type 1, it is characterized by cafe au lait spots, axillary ring freckling, skin abnormalities, neurofibromas, and then in the central nervous system, optic nerve gliomas. It is quite common, about 1 in 3 to 4,000, and it is a problem with protein neurofibrin located on chromosome 17, associated with the RAS pathway. So in the peripheral nervous system, you can see multiple neurofibromas is obviously important from an oncologic perspective, but you can see dermal, plexiform, or nodular neurofibromas. This is an example of an optic nerve glioma. As you can see here, this is a section of a optic nerve glioma, which are oftentimes polycystic astrocytomas, so benign tumors. This is an example of a sphenoid wing hypoplasia. Neurofibromatosis 2 is a little bit less common than neurofibromatosis 1. It occurs 1 in 25,000 patients, and 50% are new sporadic mutations, and about 50% are inherited autosomal dominant mutations. And the gene 2 is located on chromosome 22q, and it codes for tumor suppressor gene called Merlin or schwannomin. And genetic testing is positive in about 65% of the population, and it usually presents in young adults with hearing loss or tinnitus by bilateral vestibular schwannomas. So its hallmarks are schwannomas, especially bilateral vestibular schwannomas, gliomas, ependymomas, meningiomas, and then juvenile cortical cataract. This is the diagnostic criteria of NF2. It's either a bilateral, the patient will either have bilateral vestibular schwannomas or a combination of relatives with a unilateral vestibular schwannoma and any of the combination of other tumors that we have previously spoken about. These are some examples with the pathologic findings as well. This is an example of, as you can see here, bilateral vestibular schwannoma. You can obviously also have schwannomas in the spine. As you see here, there's a dumbbell schwannoma here. This is a pathologic specimen of a schwannoma showing the more dense Antony A areas as well as the more loose Antony B areas. This is a example of meningioma. As you can see here, meningiomas in the brain or the spine. On pathologic examination, you can see some MoMA bodies potentially or whorls. This is a example of a glioma. So microscopically, you can see these hair-like or long pilocytic-like cells which form a fibrillary mesh. And then also you will also see evidence of potential Rosenthal fibers or Rosenthal bodies, which are these red rod-like structures that can be quite diagnostic of pilocytic or low-grade astrocytomas. This is a case of a patient who have been followed at our institution for almost 15 years. It's a child who initially presented to us as a toddler, who eventually developed, as you can see here, intraventricular angiomas leading to hydrocephalus, requiring a shunt and septostomy. Later on, developed meningiomas requiring resection, multiple spinal tumors as well, requiring spinal surgery, and then over a course of about 10 years, interval development of vestibular schwannomas bilaterally. So this is something that you'll probably see in both the pediatric world, but also in the young adult world. It's definitely something that is worth noting. Moving on to another condition, von Hippel-Lindau. It is caused by a mutation of the von Hippel-Lindau tumor suppressor gene located on chromosome 3p. And when I think about von Hippel-Lindau, I think about threes. So VHL has 3 characters, is located on chromosome 3. It basically is involved with the regulation of hypoxia-inducible factor, or HIF-1A, 1 alpha. It is inherited in an autosomal dominant fashion, and CNS hemangiomas are present in 60 to 80% of the population. However, 40% of them actually present with them. And the top 3 diagnoses are CNS hemangioblastomas, retinal findings, and renal cell carcinomas. So as you can see here, again, VHL is a multi-system abnormality, multi-system disease with renal manifestations, CNS hemangioblastoma, renal cell carcinoma, but you can also have pancreatic neoplasms, cysts, pheochromocytoma, and polycythemia. CNS hemangiomas, as I mentioned previously, occur in about 60 to 80% of VHL patients, and it usually presents in the young adulthood and potentially younger if the patient has VHL. Sporadic cases account for about 70% of CNS hemangiomas or hemangioblastomas, and the rest are VHL. And they can occur along the entire neural axis and are benign and associated with edema and cysts. 50% of CNS hemangioblastomas are in the spinal cord, 37% in the cerebellum, and 10% in the brainstem. And they have various growth potential and are highly vascular, with a great stromal component. So as you can see here, this is an example of a CNS hemangioblastomas, as you can see in the posterior fossa and the cerebellum, in addition to the spinal cord. With regards to surgical considerations, small lesions can be followed. However, if they are symptomatic, usually from development of a peri-lesional cyst, you can consider removal, but with great surgical technique and care, and to remove them like a AVM, because they can be highly vascular. Next, I would like to talk about some genetic basis of neurovascular conditions. I'd like to touch upon this very, very briefly. So we have had greater understanding into the genetics of cerebrovascular disorders over the past couple of decades. And certainly it has been discovered that familial cavernous malformations can be as a result of one of 3 different genes. And these genes are CM1, 2, and 3. We've known that genetic linkage analysis in cerebral cavernous malformations have really identified cerebral cavernous malformations in 3 different loci. So CCM1 on chromosome 7q, and CCM2 in chromosome 7p, CCM3 on chromosome 3q. And these 3 gene proteins encode for CRIT1, MGC4607, and PCDC, which is programmed cell death, respectively. We've also had greater understanding into the genetic basis of Moyamoya disease, which is a pediatric, which is a disease that often presents in the pediatric population, and it is progressive cerebral angiopathy characterized by bilateral stenosis of the ICA and sometimes proximal portions of the anterior or middle cerebral arteries. And Moyamoya is accompanied by an aberrant collateral vascular network called Moyamoya vessels, as you can see here on this diagnostic angiogram. And Moyamoya in Japanese means puff of smoke. It's pretty prevalent, more prevalent in East Asian countries like Japan, Korea, China. And in fact, in Japan, up to 15% of the population of moyamoya disease are familial. So very recently we have found on linkage analysis that revealed several different loci linking to moyamoya disease, and they include chromosomes 3p, 6q, 17q, and then we have also found a susceptibility gene of moyamoya disease called RNF2313 on the 17q locus, which is very interesting. So essentially, as you can see here, even cerebral vascular disorders, we're gaining greater understanding of their underlying abnormalities and genetic linkages, and certainly gaining greater understanding into familiar forms of cavernous malformations and moyamoya disease, which are definitely conditions that we as neurosurgeons, and especially pediatric neurosurgeons, will see. And then lastly, I want to talk a little bit about the genetic basis of some common congenital neurologic anomalies, and they include craniosynostosis, hydrocephalus, lissencephaly, and holoprosencephaly. So some common genetic abnormalities are the ones that I am speaking about today are holoprosencephaly in addition to lissencephaly. So holoprosencephaly is one of the most common developmental defects at the forebrain and midface. It results in complete midline cleavage of the prosencephalon, and we've recently identified 4 major genes associated with holoprosencephaly, in addition to several minor genes that probably act together in some way to develop this condition. And we believe that holoprosencephaly results from a multiple hit hypothesis when a combination of genes are involved, and tends to be genetically and phenotypically heterogeneous. As you can see here, this is a sagittal MRI of a patient with holoprosencephaly, very abnormal areas of the brain, of course, and pediatric neurosurgeons can be involved in this disease in order to manage the hydrocephalus when it comes to performing an ETB-CPC or alternatively a shunt. Lissencephaly is characterized by a smooth brain caused by defective neuronal migration. It leads to lack of development of gyri and sulci, leading to multiple psychomotor issues, failure to thrive, spasticity, hypotonia, and oftentimes the development of seizures. We have seen many different mutations on chromosome 7, 9, 17, and also the X chromosome when it comes to its linkage to lissencephaly, and specifically isolated lissencephaly has been linked to LIS1. Congenital hydrocephalus is also something that we have gained greater understanding into from a genetic perspective, and recent genetic analysis has identified approximately 9% of males with a genetic abnormality leading to congenital hydrocephalus. And then lastly, craniosynostosis as well. Craniosynostosis is something that I will be focusing on in my talk. It is caused by premature fusion of one or more skull sutures, and is actually quite a common condition occurring in 1 in 2,500 births. And oftentimes, craniosynostosis can be syndromic, which may have a genetic underlying abnormality. So the craniosynostosis genes that we have discovered over the past couple decades, including 3 of the 4 fibroblast growth receptor or FGFR genes that may lead to several different types of craniosynostosis, and those are FGFR1, FGFR2, and FGFR3, and other mutations including the twist gene and also RAB23 have also been associated with craniosynostosis. This is a table of craniosynostosis syndromes. Of all of the syndromes, as you can see here, Aper syndrome, Pfeiffer, and Cruzon's are the most common craniosynostosis or syndromic craniosynostosis that we encounter. Recent genetic studies have identified genetic abnormalities in 21% of multisutral craniosynostosis, and of those, chromosomal abnormalities occurred in about 14%, and then single gene mutations in 86%. The most common genes involved with craniosynostosis is FGFR1, which occurs in about 32% of the craniosynostosis identified in one genetic study, FGFR3 in 25%, twist gene in 19%, and EFNB1 in 7%. And the most common craniosynostosis syndromes are Pfeiffer syndrome, which occur at 1 in 25,000 births, Cruzon, which is 1 in 100,000, and then Apert, which is 1 in 100,000. So it's more likely than not that you will be able to encounter one of these syndromes, one or more of these syndromes during your pediatric rotation with us, and that these are oftentimes surgical conditions for cranial vault remodeling, sometimes for the treatment of hydrocephalus as well, sometimes occurring in multisutral craniosynostosis. So for my talk of the craniosynostosis syndromes, I will be focused on Cruzon syndrome, which is a result of a FGFR2 mutation. It is one of the most common craniosynostosis syndromes of infancy, obviously congenital at birth, 1 in 100,000 births, and it is an autosomal dominant genetic disorder affected by a mutation in FGFR2, which is located on chromosome 10q. And the features include complex craniosynostosis, so multisutral craniosynostosis, hydrocephalus in about 30% of the population, bulging eyes or exophthalmos, hypertelorism, as you can see, white spacing of the eyes, a beak-like nose, and then maxillary hypoplasia, and then a protruding chin. So very, very common and very stereotypical facial features in addition to the craniosynostosis and hydrocephalus that you will be able to see in the central nervous system. This is actually a case of mine that I managed recently. Interestingly, unlike a lot of patients with Cruzon syndrome, this patient didn't present to us until she was quite a bit older. She was a 5-year-old girl who had very abnormal facial features, but really was unrecognized by her parents and her pediatrician. And as a result, presented late to us with findings of papilledema and poor vision. She also had, as we mentioned before, a very stereotypical features, facial features, like the beak-like nose, maxillary hypoplasia, and then protruding eyes. So with this patient, we found that she had increased intracranial pressure. She had, as you can see here from this 3D remodeling of the CT scan, multisutral craniosynostosis. So we did take her to the operating room. We did a cranial vault remodeling, orbital bar advancement, and she did very well after surgery. Papilledema had resolved by about a month afterwards. So she's doing very well. So in summary, what is new? And what have we as a neurologic and neurosurgical society really understood more of over the past couple of decades? Well, first of all, as I mentioned previously, I did not get into this, but there's a lot of further understanding into the molecular subclassifications of different tumors, including medulloblastoma and ependymoma, midline glioma. Those are ATRT. Those are just some examples of pediatric tumors that we have gained much greater understanding of. Certainly in the adult world, much greater understanding of oligodendrogliomas and then GBMs as well. Certainly the role of BRAF mutations in astrocytomas and other low-grade gliomas, in addition to H3K27 mutations in midline lesions, have greater roles in our management of patients, and certainly molecular studies and genetic testing for tumor samples are now very commonplace and standard of care. So oftentimes, if a patient with a low-grade glioma has a BRAF mutation, we will consider MEK inhibitors or BRAF inhibitors, and then we will use the H3K27 mutation as a prognostication marker as well for our midline high-grade gliomas. We have made great strides into understanding of different kinds of pharmaceutical and pharmacologic management of some previously understood diseases. For example, use of mTOR inhibitors such as everolimus and sirolimus for TSC, not just for the oncologic aspect of it, but as I presented with the results of the EXIST-3 trial, also for decrease of seizure frequency. We have identified the first susceptibility gene for Moya disease, which is the RNF213 gene, and then had greater understanding of familial cavanomas in the case of CM1, CM2, and CM3. And then we have made very great progress into the genetics of epilepsy to the point where now we are identifying about 20 to 30% of all epilepsies with a genetic underlying abnormality. And certainly in larger epilepsy centers like ours at Nicklaus Children's Hospital, genetic panels are now standard of care. And certainly we use it to diagnose and to prognosticate familial epilepsy, channelopathy, epileptic encephalopathies. So in summary, as we wrap up in the last 10 minutes of our talk, today I talked about really the understanding the basis of genetic transmission, associated conditions, modes of inheritance for many different types of commonly seen pediatric neurosurgical conditions for neuro-oncology, epilepsy, cerebrovascular disorders, in addition to congenital pediatric neurosurgical abnormalities. And hopefully I will have given you a greater understanding of the genetic underlyings of many of these conditions, the mode of inheritance, the frequency, in addition to its applicability to neurosurgery from all of the cases that we have spoken about as well. I would encourage you to consider genetic basis for really every realm of neurosurgery, everything from neuro-oncology, which is the most frequently encountered subspecialty with a genetic underlying, but also for epilepsy, hydrocephalus, craniofacial abnormalities, and other congenital abnormalities, and then understanding their applicability to pediatric neurosurgery, but also to adult neurosurgery. So thank you so much for your attention today. If you enjoy pediatric neurosurgery as much as we do, and if you enjoy learning about those conditions, I would encourage you, if you haven't already, to join us for our Miami Pediatric Neurosurgery Symposium. We have had 2 sessions so far, one on the pediatric neurosurgical oncology evolving landscape, which was actually a great talk by Drs. Guvnerova, in addition to Dr. Swedane, on some of these specifically pediatric neuro-oncology, but a lot about the genetic abnormalities of these conditions. We've also had a great talk with Dr. J. Riva-Cambrin about the hydrocephalus clinical research network, which is the HCRN, and some of the clinical trials occurring in the HCRN now. And then our next symposium will focus on Moya disease, which I talked a little bit about during my lecture. But of course, if you're interested in cerebrovascular abnormalities, I encourage you to join in next Monday with us for a great talk with Dr. Smith, Dr. Scott from Boston Children's Hospital on the surgical management of Moya. So thank you so much for your attention, for your time today. I hope that talk was informative, and I would encourage any questions or any comments right now.
Shelley, thanks. This is John Raggett. I think that's a wonderful review. What I think is really worth stressing is the fact that we as neurosurgeons will commonly be the first person to see a patient with an undiagnosed genetic syndrome that involves the CNS. And I'm sure all of the faculty can come up with an example of a patient where they've seen. So, for those who don't think pediatric neurosurgery will be part of their practice in the future, you will see a patient in the future with an undiagnosed genetic syndrome. And if you're unaware of the syndromes and their manifestations, you'll stumble into treating a symptomatic lesion in isolation. And that's a big mistake often. Great examples are the patient that presents with a single neurofibroma that has NF, where your management may change the initial manifestation of somebody with multiple cavernous malformations, et cetera, et cetera. So I think it is not just an abstraction. It's not just for the pediatric neurosurgeon, and we will often be the first person to see these patients and make the diagnosis. But it's a really wonderful review. Thanks.
Thank you so much, Dr. Raggett.
I assume Dr. Morrison's not on the call. He doesn't get up early anymore, but he used to love to say that the lady who was the woman in charge of the TS Family Association took exception to the triad of epilepsy, adenomyosis, and mental retardation. So, I think you have to be careful about these classic triads. Mm-hmm. She really did not like the label of being mentally retarded.
Yes, absolutely.
Thank you for the review.
Wonderful. Well, thank you so much. Oh, there's Dr. Morrison.
Actually, John, I am here, and it was what she objected to mostly was the old FLK.
Yeah, that
anything like, huh?
Very inappropriate.
Funny-looking kid.
Yeah. Thank you, John, for that wonderful review.
Great. Thank you very much for your comments, Dr. Morrison, Dr. Raggett. Thanks, Dr. Levy and Dr. Landy, for the opportunity to speak today. And I hope some of you guys will be able to join us next Monday for a Moya Moya talk. Take care. Have a great day.
Thanks, Shelley. I was going to introduce our next speaker, who's Dr. Helen Bramlett. She is a professor of neurosurgery at the Miami Project. She is not only a phenomenal researcher and teacher, she's also the vice president of the faculty council. I'm not sure if the vice president is the actual name of that position, but is essentially second in command, which is a huge job, and we thank her for representing us. Her talk is going to be on targeted temperature management, as seen on the slide here. And Helen, thanks for speaking to us.
Thank you very much, Dr. Levy. Thanks, Dr. Landy. And I'd like to thank Roberta and Eva for inviting me today to talk about some of the work over a few decades. I'm going to give you a history lesson of our lab, looking at targeted temperature management as well as therapeutic hypothermia, and some of the more recent work that we've been doing in terms of inflammatory mediators of injury after TBI. So these are my disclosures, and as Alan said, I'm second vice chair. So VP, no, but yeah, that's what that's all about in terms of council. Just an outline, brief history of hypothermia and introduction. I'll talk about some of our work in TBI over several years, temperature mechanisms of action, the inflammasome, which is what we've been targeting lately for the past probably 8 to 10 years. Looking at concussions, hyperthermia, which of course everyone in this audience knows. Hopefully I won't be too redundant in some of my information I'm going to pass on. Talk about biomarkers and give some concluding remarks. So some of you may or may not know, I'm sure this is a very well educated neurosurgery audience. In terms of the history of therapeutic hypothermia, basically the Edwin Smith papyrus, which was dated 3500 BC, had numerous references to cold as a therapy. So this is probably the first medical document describing the use of some type of cold therapy. And next up we had, this is an interesting case report. If you haven't seen this, probably most of you have, but Anne Green was hung in 1650 she had a stillborn birth, and she was accused of murder, and she was found guilty. So they hung her, and it was very cold outside, and her family was also pumping on her chest with a stick, as you can see here, and pulling on her legs. And after about 30 minutes of hanging, they took her down. They figured that she was gone. But what happened was, when they took her to the University of Oxford for anatomy lesson, she started to stir. So it's thought that perhaps low body temp during hanging, as well as some type of cardiac massage, actually prevented her from asphyxiating. And then we had some other work done by Giovanni Aldani, basically providing electricity to dead corpses. Obviously, they're cold. And Aldani was the nephew of Galvani, as everyone's familiar with. And it's thought, actually, that Mary Shelley's father could have been in the audience during these demonstrations, and which resulted in maybe him telling her stories, and she ended up writing Frankenstein. And then we had Philippe Pannell, French doctor, in 1791, actually used therapeutic hypothermia, or cold therapy, for mental illness. This was probably not a slam dunk, but they were doing this back in the late 1700s. Most of you are probably familiar with Napoleon's Russian campaign, with the physician actually using ice or cold as an anesthetic when they had to do amputations. And of course, Dr. Temple Fay, very famous neurosurgeon, really pioneered the use of refrigeration or hypothermia or cold therapy in cancer, as well as head trauma. So as you can see here, this is just a table illustrating the history of hypothermia going back 17th century all the way up into the late 80s and mid 90s in our own laboratory. And I'm going to talk about some of that work. Of course, we had Dr. Rossimoff, a former chair of neurosurgery, did some of the seminal work in hypothermia with head trauma in the 50s. And then Peter Saffer, of course, with resuscitation in the 1960s. So where did we have a breakthrough? Basically, a lot of work was done in the preclinical setting with the use of mild to moderate hypothermia in a variety of CNS injuries. Some of them are shown here: global cerebral ischemia, which mimics cardiac arrest, neonatal hypoxia, ischemic stroke, TBI, as well as SCI. And also, more recently, the use of targeted temperature management in order to prevent fevers in the ICU has been employed. And we now have a journal. The journal is going on its 11th year, actually. So we're very happy with this journal. So if any of you guys are doing any type of temperature work, I know we've got some clinical trials going on at in the Department of Neurological Surgery at UM. Feel free to submit your manuscripts to the journal. So this was the first seminal preclinical paper that we did in the laboratory published by Dr. Dietrich and Professor Busto, looking at small differences in intraischemic brain temp. And, this was published a really long time ago, 1987, but it was really an important paper because it showed very elegantly that if you drop temp after global cerebral ischemia in an animal model, you could prevent CA1 cell loss, whether it was 30 degrees, 33, and even 34. But if you elevated temperature after global cerebral ischemia or during the ischemic episode, with hyperthermia at 39C, you actually worsened outcome, and you had much more cell death in the CA1 hippocampus, which is a vulnerable area after a cardiac arrest in the animal model. We are still cooling after all these years. I updated the slide, and you can see here a little bit of a drop off, probably due to COVID-19, but people are still doing and publishing the use of targeted temperature management as well as therapeutic hypothermia. So I don't need to preach to the choir on this one in terms of TBI epidemiology, but worldwide estimates 10 million, 1.7 million Americans sustain a TBI. Post-concussion syndrome affects about 4 to 43%, and I'll touch on that a little bit later on in my talk. The annual cost about $76.5 billion annually. So it's a big hit. However, as most of you know, we have a lack of treatments for traumatic brain injury. Several reasons have been given for their failure: pharmacokinetics, treatment dose of drugs, therapeutic window, scientific rigor of the experiments, whether they're preclinical or clinical. But most importantly, I think it's the heterogeneity of the TBI population. It's just so wide ranging. And I know you guys see that clinically. So I'm going to present some of our own data looking at a preclinical model. This is the fluid percussion brain injury model. Basically, the animal craniotomy is done over the right parietal cortex and a parasagittal, and an injury cap is placed and the animal is anesthetized. We run lines in our animals, and you can raise the pendulum back, hitting the plexiglass cylinder and producing a fluid pulse, which impacts the brain. And these are just some 3-day pathology with H&E stains showing a very nice gliding contusional injury. Many injury mechanisms that you'll see clinically, such as blood flow, glucose, neuronal loss, axonal injury, we see in this model. And if we let these animals live for a year, you can see here, we also see cortical atrophy. This is H&E with a Loxol Fast Blue for myelin, and shrinkage of thalamus as well as hippocampus and expansion of the lateral ventricle. This occurs ipsilaterally, it does not occur contralaterally. So this, of course, a nice slide, schematic graph from Dr. Dernagel a while back, but clearly showing a lot of different secondary injury mechanisms that could be targeted after trauma, and also cerebral ischemia as well. Early on, excitotoxicity, later on, inflammation, apoptosis, and we also have some protective mechanisms that perhaps that we can enhance. So this is just a laundry list of the temperature mechanisms that have been investigated after ischemia and trauma, and a lot of these studies we have done ourselves, but clearly showing that small variations in CNS temperature influence many of these secondary injury cascades. This is a nice review article looking at the neuroprotective effect of hypothermia at the cellular level. And if you'd like to take a look at that. So this is clearly showing therapeutic hypothermia affects a lot of different components within the cell, as well as those that are activating events outside of the cell. Mimi, Dr. Unari, and Dr. Hahn published a very nice neuroprotective mechanisms of hypothermia and brain ischemia review, and basically demonstrating a lot of these secondary injury mechanisms again, and going over them in detail. But I wanted to point out this particular slide, this image on this slide. We like to think of this cell death as a spider web phenomenon. And I think Dr. Dietrich may have coined this. So if you think about a cell in the middle of a spider web, and you have all of these secondary injury mechanisms that are targeting at this cell, you give a drug, okay, you stop that particular secondary injury mechanism. However, what happens is another one gets activated or is activated already and ends up killing the cell. So you need something that's going to target cell death, survival, and improve survival pathways, inflammatory mediators, blood-brain barrier, neurogenesis, gliogenesis, et cetera. So you want some type of neuroprotective strategy that has multi-potential factors. So this was our first study that we published in 1994, when I was a very small child, by the way, by Dr. Dietrich and colleagues. Basically, after fluid percussion brain injury, hypothermia was initiated 5 minutes after trauma. And at this time, we were doing 30 degrees C and for 3 hours. But clearly showing the black bars are the hypothermic animals, and we had a decrease in necrotic neurons over the cortical areas where the contusion is, as well as a decrease in contusional areas. Dr. Globus and colleagues in the lab then went on the next year to publish a decrease in glutamate release after fluid percussion brain injury with the same paradigm for the hypothermia. And of course, this was very acute because it's excitotoxicity, but using microdialysis clearly showed a decrease in glutamate release relative to the normothermic TBI animal. Dr. Katsipatelli, who is a postdoc in the lab in 2000, also demonstrated with mild peroxidase assays, which is a marker for neutrophil infiltration. And if you just concentrate on the P1 section, that's the cortical area that is overlying the contusion, clearly showing a reduction in MPO protein, as well as an increase with hyperthermia. So hypothermia was neuroprotective, hyperthermia actually aggravated neutrophils. Dr. Kinoshita in the laboratory in 2002 published a paper looking at inflammatory cytokines. We've done a lot of work on inflammatory cytokines. This paper in particular, we upped the temp now about 33 degrees C for 3 hours. The animals were sacked immediately after that 3-hour time point, and again showing a decrease in IL-1 beta cytokine in particular with hypothermia, and an increase within the ipsilateral hippocampus, and a structure that is vulnerable after TBI and involved in learning and memory, and hyperthermia seemed to aggravate IL-1 beta production. We then more recently have looked at microRNAs. These are small endogenous non-coding RNAs. They regulate gene expression. Did a study looking at an in vitro stretch injury model showing just microRNA overexpression increases cortical neuronal vulnerability to injury. This is a stretch injury model with neuronal cell cultures. And then we also did some therapeutic hypothermia work after TBI in rats, again showing an alteration with microRNAs. And actually, so you have elevated microRNAs, and they're resulting in gene activity and proteins that are not good. But with hypothermia, you see a blunting of certain microRNAs, so indicating another pathway, secondary injury pathway, that is reduced with therapeutic hypothermia. We also have looked at some protective or repair mechanisms, such as neurogenesis after TBI in our model. This paper was published by Dr. Breggy and colleagues, another postdoc in the lab, clearly showing here when we did TBI and hypothermia with looking at neurogenesis as expressed by double cortin. 7 days, we saw an increase in double cortin positive cells within the dentate gyrus, again, of the hippocampus. So hypothermia may be important in not only protection, but also repair as well. More recently, we've started to delve a little bit further on into inflammation, and this paper was published in 2017 looking at post-traumatic hypothermia and microglia and macrophage polarization. This flow cytometry graphs the B through E are normothermic animals at different time points, showing an increase in microglia as well as an increase in infiltrating leukocytes. And the flow cytometry time course F through I shown here are the hypothermia animals, clearly showing a decrease in microglia as well as infiltrating leukocytes. We went on to look at M1 and M2 associated genes. These are M1 microglia, M2 microglia. This is a little bit antiquated. They've kind of changed some of the nomenclature for these different types of microglia. But again, M1 associated genes are bad. M1 microglia are bad. They produce cytokines or pro-inflammatory cytokines, whereas your M2 microglia are producing anti-inflammatory cytokines and other releasing other factors. But clearly with M1 associated genes with hypothermia, 4 hours, we saw a decrease relative to the normothermic groups. And with M2 associated genes, we saw an increase at 4 hours. So early on, we saw some changes with these M1, M2 microglia phenotypes. So this is some more recent work. We're working with Dr. Sylvia Donner, who's the chair of biochemistry. I just wanted to throw this out here. She recently got an R21 from NIH that we're doing the in vivo work with her. They've developed some nano drugs that actually can cool. They are vanilloid compounds. This is a group of them right there. We're actually looking at Renvanil and Arvanil. and they are agonists to the transient receptor potential vanilloid 1 brain receptor, and it's known to control thermoregulation processes. So we did some pilot animals for the R21, but clearly showing that when we administered nasally these nanodrugs, this nanodrug in particular using Renvanel in this way they've packaged it, we saw a decrease over time in both brain and body temp. So now I'm going to go back and start to look at TBI as well as modifying, and we're going to use telemetry systems so we can actually have the animals awake as opposed to being anesthetized, which, as most of you probably already know, anesthesia also can affect temperature. So I'd like to switch gears a little bit and delve a little bit further into inflammation. And I like to think of this as the next frontier for anti-inflammatory drug discovery and a potential target for temperature management, the inflammasome. Some of you may or may not be familiar with the inflammasome, as we've been working on this since, God, I think 2006. It's been a while.
Hey,
so when you look at the inflammatory response,
Helen,
someone say something.
Yeah, hey, it's Alan. I just before you move on to the next topic, you know, and you mentioned it early on, how robust the data is for neuroprotection of hypothermia in animals, but not so much in people. And I think you're absolutely right. It's the heterogeneous nature of our head trauma population, and working in animals, everything is super controlled. Every animal is the same size, same sex. The injury pattern is the same. The one thing, and you may have showed it, is it definitely reduces neuronal injury without a question. But does it delay or abrogate? And I'm sure you've done time course studies looking at the long-term outcomes, correct, of hypothermia.
Right. So we've actually. Right. When we've done therapeutic hypothermia, we've looked a year out with our atrophy assessments, and we saw a decrease, a lack of atrophy and a decrease in the ventricular enlargement in our animals chronically. And we've also seen, just touching on what the last speaker spoke about, we've also done, we've done a lot of seizure work as well, post-traumatic epilepsy work. And when we cooled these animals early on, 2 months later, they didn't have as many seizures, or we couldn't induce the seizures as well in those hypothermic animals relative to animals that had undergone just regular, TBI and normothermia. So I think you do see long-term improvement, and we have seen. So you do see long-term improvement. I didn't touch on any of the clinical studies in this talk, but
right. The next question is the signal as robust in the chronic as is in the acute phase? Because I can tell you, when we're doing these studies, we're looking at a week, a month, a year out. So those are where our endpoints are. They're not so acute. And so is the signal as robust on a chronic basis in general? Because I always worry that what we're seeing is it's just delaying neuronal cell death, hypothermia, and that.
Right. So I mean, that is an issue, but I think if you're able to stop some of these secondary injury cascades that are occurring early on, I think you will see long-term improvement. I mean, as you all know, hypothermia reduces ICP, for example, very well. And, it's used to that. It reduces fever. I mean, hyperthermia aggravates long-term outcome. I mean, we've seen improvements with cognition late in our animal models. So, I mean, obviously behavior, I think, is the gold standard. So let alone, saving cells, you want to see if you can improve function in these animals and in people. So even in our own studies, we've seen long-term, let's say 3-4 weeks out, improvement in cognition and let's say sensory motor behavior in our animal models. So I think if you look at it from that, not just looking at a Glasgow outcome scale or something like that, but using it at a more intense neuropsych assessment of these individuals, hopefully, there is some, they are improving, and especially with our rehabilitation strategies that are being used clinically now as well. Okay. We'll switch gears just a little bit. Okay, so when you look at the inflammatory response, you can divide it up into the innate immune response as well as adaptive immunity. So innate immunity early on involves a lot of the different pattern recognition receptors, and adaptive immunity is more of a response of our T and B cells to some type of injury or disease. But what we've been looking at in the laboratory is the inflammasome. Okay, it's a multi-protein complex. It's involved in the activation of caspase-1 and several pro-inflammatory cytokines. There are different types of inflammasomes, and you can see some of them down here in NLRP1, 2, 3, and AIM2. But what is common to all of them is this component of ASC, which is a apoptosis associated speck-like protein containing caspase recruitment domain. So basically what happens, the inflammasome is activated after CNS injury or even disease as well. So you've got dying cells, they're releasing ATP, and ATP is activating the P2X4 receptor, and you've got potassium efflux, pannexin 1 is activated, pannexin 1 receptor forms interacts with the inflammasome, shown down here. Pannexin 1 releases ATP, which activates another pannexin receptor, P2X7R. Inflammasome is activated then, okay, and then what happens is XIAP is cleaved off of the inflammasome, and then you have these ASC caspase-1 filaments that ultimately result in activation of IL-1 beta, IL-18, and these filaments are released as well as cytokines from the cell, basically resulting in inflammation and cell death, leading pyroptotic cell death in this particular case. These are, if you want to read more about the inflammasome, Dr. De Rivera-Vicari has written a couple of really nice reviews on the inflammasome and some of our own work. So we've looked at the inflammasome and targeting ASC or NLRP1 in a variety of different CNS injury models. This is spinal cord injury. We showed an improvement in function as well as a decrease in inflammation or the inflammasome. And we also inhibited inflammasome complex after stroke in mice with NLRP1 or NALP. We also have done this in TBI and showed a reduction in pathology when we targeted ASC in our own fluid percussion injury model. Dr. Stephanie Lee, who was a MD PhD student in the lab, also looked at the penetrating ballistic-like brain injury model. This is a model that was developed at Walter Reed and mimics gunshot to the head, and basically showed clearly that after PBBI, there was an increase in microglia as shown here, activated in amoeboid microglia with using IBA1 as a stain, and these IBA1 stained cells were also positive for ASC, again, a component of the inflammasome. So look like this model also increased inflammasome activity. Dr. Tamura, who is a postdoc in the lab, also looked at the inflammasome and therapeutic hypothermia and clearly showed that after fluid percussion brain injury with hypothermia, there was a reduction in caspase-1, a component of the inflammasome, and caspase-11, and showed a reduction using immunohistochemistry that caspase-1 in cortical cells was down. Also saw a reduction in the P2X7 receptor, which is a receptor activated in that particular inflammasome pathway. So Dr. Kerr, who was a PhD student in the lab, now is a postdoc, also looked at the inflammasome. And she published really for the first time looking at traumatic brain injury induced acute lung injury. So now we're talking about TBI and affecting other organs systemically. And Nadine did a really elegant study for her graduate work looking at the neurorespiratory inflammasome axis. And if you're just looking at these Western blots over here, this is cortex and lungs after controlled cortical impact injury in the mouse, clearly showing at 4 and 24 hours an increase in components of the inflammasome in the cortex. And then she took out the lungs as well after trauma and saw an increase in inflammasome components within the lungs. She went on to do another study looking at adoptive transfer and basically injured the mice, took out the blood, isolated extracellular vesicles, injected them back into a naive mouse, and showed with these untreated, you can see the untreated right there, an increase in caspase-1, ASC, IL-1 beta within the lungs of these naive animals. And when these animals were treated with enoxaparin, which is a low molecular weight compound, as well as an anti-ASC antibody, which both of these are targeting the inflammasome as well as inhibiting extracellular vesicle activity, she saw a decrease in these components of the inflammasome. And actually, when you look at acute lung injury score, there was a reduction in that particular score for these naive mice. So clearly showing a systemic response after TBI to the lungs, and she's actually now gone on to look at the gut and seeing similar responses. So there is a systemic response, inflammatory response in particular, within the body after traumatic brain injury. So I've talked mainly about temperature, CNS injury, and I'm going to switch gears a little bit again and talk about fever in terms of how it accelerates injury, and mention a couple of our studies that we've done over the years. First one, really long time ago, prior to the TBI work, looking at hyperthermia, 39 degrees after forebrain ischemia, clearly showing an increase in ischemic cell counts. We all know that fever is bad. And basically, in this particular study, there was a transformation from selective injury to frank infarction in these animals. More recently, we've actually looked at mild hyperthermia aggravating glucose metabolism in our repetitive concussion model. So now we're talking about mild fluid percussion brain injury. Animals underwent 3 different repetitive hits of mild TBI using a weight drop model, and showed with hyperthermia a reduction in glucose levels in a variety of the different structures that we assess, but you can clearly see that in these autoradiograms showing a reduction with hypothermia in glucose and normothermia in sham animals actually, are fine. So again, I don't have to preach to the choir. Fever in the Neuro ICU is really bad. This is a study published in 2000, but clearly showed that there was a strong correlation with fever and length of stay. And a lot of patients in the ICU have fever, and it does need to be monitored with targeted temperature management. This is a clinical trial, just through one clinical trial in here for you. Dr. David Greer at Boston, the Intrepid trial looking at the impact of fever prevention in brain injured patients. And they're targeting a lot of different ones: stroke, intracerebral hemorrhage, as well as subarachnoid hemorrhage. This is assessing the whether or not temperature management using a systemic cooling device versus standard fever care, which one's better. And this study is still ongoing, and they're still recruiting patients. I think the study goes until 2022. So what about concussion, mild TBI? I showed you some on the repetitive concussion work that we've done with glucose metabolism, but estimated concussions worldwide are 51 million a year. So a lot of concussions. Some of these individuals don't make it to the ER. They just kind of wait it out. But a lot more concussions as opposed to just moderate and severe trauma. The issue with concussion is that you can have persisting symptoms, and a variety of these symptoms in this review paper. They can be acute. They can last a minimum of 3 months. They can last a while. So we wanted to ask the question in the lab, is temperature an important variable in recovery after mild traumatic brain injury? So clearly showing here that in subjects that exercised and then during the recovery period, the finding was that the venous blood supply, venous temperature was high. It was at hyperthermic levels actually after bicycle exercise, and during recovery it did drop. But when you compare it to arterial blood temperatures, arterial blood was much cooler. So what's happening in the venous blood, and the brain does have a higher temp than the body core during exercise. So exercise can impact, let's say, someone who is, I don't want to go too low on the aged person, but let's say someone who's 72. Oh, there's no 72-year-olds on the talk, and they're playing tennis and they fall and they hit their head and they're hot. So it's not a good thing. So in terms of the interaction of temp and experimental mild TBI, okay, so you got 250,000 ER visits, basically related concussion from sports or recreation related concussions. And we all know that small variations in brain temp can affect the pathology. And many athletes and our soldiers may experience a mild TBI concussion and with elevated core and brain temp. So we did a study with Dr. Sakurai, who was a postdoc in the lab, showed that mild hyperthermia after mild TBI actually worsened neuropathological damage. And this graph just shows a decrease in normal neurons in the cortex with hyperthermia compared to normothermia. Dr. Atkins and Titus in the lab went on to look at cognitive deficits with mild traumatic brain injury using the fluid percussion injury model, as well as the cognitive assessment was looking at fear conditioning. And just to point out that when the animals were given a cue after they had already been trained to associate the cue with the electric shock, those animals that had undergone hyperthermia or elevated temperature had a marked decrease in the freezing response, which normally, if your cognition, if you were intact, you would freeze when presented with the cue, because it was associated with an electric shock. Interestingly, when these animals, with temperature, with hyperthermia, and then they were brought back down to normothermia, they did not have a cognitive deficit to the cue in terms of the electric shock. So bringing someone back down or an animal back down to normothermic level after a fever, after hyperthermia, seemed to improve cognition. We also went on to look at hyperthermia mild TBI in terms of our M1, M2 macrophage microglia phenotype polarization, and again saw that hyperthermia after mild TBI did promote M1 microglia macrophage phenotype with higher microglia and infiltrating leukocytes within these animals at 24 hours. We also did some quantification on microglia using IBA1 stain, and again showing an increase with hyperthermia in the cortex, an increase in reactive as well as amoeboid shaped microglia. So, patient heterogeneity issues, and Dr. Levy brought this up. So how are we going to deal with this? When you look at patient heterogeneity, you can look at this cascade, which I showed you a graph earlier, basically showing CNS injury pathophysiology. We have the potential to use these injury cascades as an avenue to look at biomarkers for targeting either with some therapeutic hypothermia or some type of drug therapy that would target particularly, a biomarker for inflammation, for example, and you don't see anything else, maybe. It's just going to depend. So there's a lot of different biomarkers early on, out to months or years, that can be investigated. So we've been targeting the inflammasome as a biomarker. And this was a study done by Dr. Adamczak. She was, again, an MD PhD student in the lab, now a neurosurgeon, and looked at, took CSF from TBI patients, and they were classified as unfavorable or favorable outcomes based on Glasgow Outcome Scale at 5 months, and clearly showed those that had an unfavorable outcome, they had significantly higher levels of ASC, caspase-1, and NALP1 or NLRP1, clearly indicating that inflammasomes were active. And here's an example, Alan, of 5 months, okay, post-injury, where these early, biomarkers were showing an issue in terms of outcomes at this later time point. Dr. Kerr also did some biomarker work in TBI as well, and this was serum that was taken from TBI patients. On the first and second sampling was done on day 1 post-injury, and fourth and sixth samples were taken on day 2. Again, showing ASC and caspase-1 in the serum are potential biomarkers after TBI. And these are just the ROC curves showing that these particular ASC and caspase-1 were predictive of outcome, and they can be used. We think these inflammasome proteins can be used as a diagnostic as well as a predictive biomarker for TBI. So in closing, I just want to reiterate, this is a nice summary that Dr. Rincon published a couple of years ago. Basically, our evidence from our animal models, I know it's animal models, and they always work fairly well for the most part in terms of our temperature studies. But just by lowering the temperature for a few degrees, you don't have to go down to 30 degrees anymore in our animal studies. We go down to about 34, 35, which is a lot more clinically relevant. We actually wait 30 minutes before we do induce therapeutic hypothermia, and we're doing therapeutic hypothermia a lot longer now in the laboratory. But I think we still need to continue the preclinical research, looking at molecular mechanisms underlying temperature-dependent cell protection. Obviously, targeted temperature management can provide neuroprotective effects. Hopefully, these are long-term clinically. We do see them effective short-term in our animal models, but because of some of the work that was done at Miami, resulted in changes in the guidelines for cardiac arrest and neonatal hypoxic ischemic encephalopathy as well. It's recommended that hypothermia is used. And of course, maintaining normothermia in the ICU, preventing fevers after CNS injury is very important and is generally considered a standard of care in the ICU. And we do have some ongoing clinical trials, even at Miami. We have the HOPES trial, which I didn't talk about, but that's basically cooling prior to decompressive surgery to remove a subdural hematoma, and then cooling the patient afterwards. And then, of course, the DoD grant with Dr. Levy as PI, looking at spinal cord injury and therapeutic hypothermia as well. And I think, future research refining patient selection based on biomarkers, and what therapy, whether it be hypothermia, whether it be some drug or a combination of both, what you're going to use to treat your patient. And I will just say that we have a graduate student in the lab who's finishing up, and she's been using machine learning on our preclinical data sets from our large consortium, looking at what factors will help in predicting outcome as well as guiding therapies. And she'll be moving on into clinical data sets in the future. Of course, none of this work gets done without everyone in the lab, as well as colleagues, faculty here at UM. And just like to thank our funding agencies, NIH, DoD, the VA, as well as the Miami Project. And I know everyone's familiar with this, and thank you very much. Any questions? Doesn't look like it. Okay. Well,
Well, that's awesome, Helen. Thank you so much for doing this, and
you're
we'll hope for
welcome.
we'll hope for another update real soon.
Yes, we will continue pushing forward. We're really interested in the nasal cooling, and we're looking forward to getting that work started, because that's going to be easy to translate, we think, into the clinic. So you can just, spritz up the nose and drop the temp.
Great.
Okay, I hope everyone has a great day. Yeah. Okay. Thank you.
You.
Okay. Bye-bye.